All right, so we're going to start out with just some questions. We'll go through the answers at the end, but I'm going to let you look at the questions, think about the answers, and then see whether or not during the course of my presentation you get the answers to these questions. So this is the first one. From clinical trial evidence, which of the following types of diabetes can be prevented? And you have your four options there: type 1, type 2, gestational, and steroid-induced diabetes. All right, question 2. Clinical trials of diabetes prevention have been conducted in all of the following populations except. And here you have 1, Chinese men and women, elderly Americans, women with gestational diabetes, obese children, or persons at risk of type 1 diabetes. All right, question 3. Which of the following are proven risk factors for type 2 diabetes? And you have the options there: obesity, sugar-sweetened beverage consumption, having a first-degree relative with diabetes, gestational diabetes, or being sedentary. And you can have more than one answer to some of the questions. So the first two should only have one answer, but this one you can have more than one. So tick these off in your mind, because these will help you to identify the persons who are at risk. You'll be given a clue already because you have that handout, your risk calculator already, so you know which ones are coming. All right. Prediabetes. Prediabetes refers to which of the following results? And this is something that we're going to talk about, so hopefully you get the answer. And in this case, there's only one correct answer. So fasting glucose between 5.6 and 6.9, total glucose after 75-gram oral glucose tolerance test between 7.9 and 11, and A1C between 5.7 to 6.9 on a NSGP standardized assay, or any of the above, or all of the above, I guess. Question 5. Most diabetes prevention studies have been conducted in populations that meet which of the following criteria for prediabetes? Fasting glucose 5.6 to 6.9. Okay, good. 2 hour after 75 gram. A1C between 5.7 and 6.9. All of the above. Which of the following medications have been demonstrated to reduce the risk of diabetes in patients with prediabetes? And this one can have more than one answer. And if you are sleeping, you will know at least one of these should be correct. Metformin, pioglitazone, acarbose, liraglutide, orlistat, and you have none of the above. Which of the following medications have been approved by the U.S. Food and Drug Administration for diabetes prevention? I have metformin, the same list as before. Pioglitazone, acarbose, GLP-1 receptor agonist, orlistat, none of the above. The Diabetes Prevention Program found that lifestyle was most effective in preventing diabetes among which of the following groups of persons? Men, those with elevated fasting glucose, participants over 60, participants under 45. We'll talk about that study. All right, coming to the second to last question, it's only 10. Which of the following medications have been demonstrated to reduce the risk of both cardiovascular events and diabetes? You have metformin, pioglitazone, acarbose, atorvastatin. Okay, wait, I think one of my answers is wrong when I'm looking at it. Anyway, we'll skip that one when we get to the end. Which of the following have the potential to reverse diabetes? So this is like a little twist I'm putting on it, and because it's something you hear about nowadays, very topical: bariatric surgery, metformin, very low calorie diets, sitagliptin. Okay, all right, so with that in mind, see if you can make sure of what you want to hear when I'm presenting. So what we're going to talk about today is listed here. We're going to talk about the natural history of type 2 diabetes specifically. And our focus is going to be on type 2 diabetes, really around issues of identifying those at risk by recognizing the modifiable and non-modifiable risk factors, and then also a particular condition, prediabetes, which is one of the things that will help us to identify persons who are at highest risk of progressing to diabetes, mostly type 2 diabetes, and I'll explain why the prediabetes designation is more important in the setting of type 2 as opposed to type 1 diabetes. We'll talk about why this particular scenario is important when it comes to prevention of diabetes. I'm going to go through several trials which have looked at prevention of diabetes in persons at high risk based on the presence of prediabetes. And since you said medical management, it's going to include pharmacological and non-pharmacological interventions. And then just a brief word on some of the newer approaches that might potentially be possible for preventing type 2 diabetes. All right, so what is diabetes? Everybody knows sugar, as they say in Jamaica, but even though the blood sugar elevation is the main thing that helps us to recognize that diabetes is present, it's really a sort of metabolic condition, because not just the blood sugar is abnormal, you have problems with lipids and other things as well. And it is produced from either absent or insufficient amounts of insulin production by the body, or it may be inappropriate utilization. So your acute complications we know about. These are the ones that can kill patients. We have the ketoacidosis in patients with type 1 diabetes or severely ill type 2 diabetes, where there's acid buildup and risk of death. But more importantly, the hyperglycemic hyperosmolar state, which is what we see in a lot of elderly patients who have uncontrolled diabetes, actually has sometimes a higher mortality because it is also associated with the presence of more complicated conditions like stroke or heart attack. And of course, the low blood sugars can also be dangerous. And the chronic complications are what we are concerned about, because these are the things that tend to produce a lot of increase in terms of healthcare costs. And these would be divided into your microvascular or your macrovascular complications. Microvascular are the small vessels, so that would be issues around the eye and the kidney and nerves. And macrovascular would be the heart disease risk, peripheral vascular disease, and then amputations can be a combination of both, because amputations can result from vascular disease as well as nerve damage to the foot. So one of the things that we have to remember that is for diabetes usually doesn't develop overnight. In the case of type 1 diabetes, it's a lot faster, from moving from a normal blood sugar state to the point where the blood sugars are elevated and there's a diagnosis of diabetes. But for type 2 diabetes, this transition is not as rapid. It usually takes place over a longer period of time. And that even though patients will eventually become symptomatic when the blood sugars get to a certain level and have their increased thirst and urination, weight loss, and all the other things we know are associated with diabetes, there's a long period of time where people will have blood sugars high enough to classify them as having diabetes, but have no symptoms. It's pre-symptomatic phase. And where they have done studies where they've tried to estimate how long this is, they have found that if you're looking at complications and how long they tend to develop, a lot of patients have had diabetes for 3 to 5 years prior to the diagnosis being made. So for a long time, there was no consensus about how we should define diabetes. And then in 1985, the first attempts at classification of diabetes to make it standard worldwide were made. But in 1997, the American Diabetes Association kind of changed around the way in which we should work to diagnose diabetes. When the first definitions were made, it was always based on a glucose tolerance test. So to diagnose diabetes, they'd come in, do the fasting, get the glucose, and 2 hours later get their blood sugar checked. If it was abnormal, then this is how you classify them as having diabetes. But one of the concerns that they had was that waiting for people to do the glucose tolerance test was really not very convenient. And they were missing out a lot of people who had diabetes or who could benefit from treatment by taking that approach to the diagnosis of the condition. So the American Diabetes Association said we don't need to do glucose tolerance tests on everybody. We can just use a fasting glucose only to make the diagnosis of diabetes. And so that is where this definition that emerged in 1997. So if you have symptoms of diabetes and you do your blood sugar and it's more than 11, that is enough for a diagnosis. If you have no symptoms you have a couple of options. One is you can do a fasting glucose, and if that fasting glucose is more than 7 on more than one occasion, then you have made your diagnosis of diabetes. Or if you want the person to do the full glucose tolerance test, use the 2-hour glucose reading, and if that value is more than 11.1 or more on more than one occasion, you have also made your diagnosis of diabetes. So symptomatic patient, a random glucose diagnosis made. Asymptomatic patient, you have the option of using the fasting glucose or doing a glucose tolerance test. If it is abnormal, it should be repeated on at least another occasion before you label somebody as having diabetes. And this was to make it easier for us to identify people who have diabetes and begin treatment earlier rather than later. And a lot of the data they used to use the fasting glucose came from studies like these. So I don't have my pointer, but one of these some data from the Pima Indians in the US, and what they looked at was how common a specific complication of diabetes was based on persons fasting glucose. Okay, I have to point to the screen. Okay, all right. But one of the things that they did see is that the prevalence, the frequency with which they found retinal disease, which is very specific to diabetes, increased when you got to a blood sugar of about 117 milligrams per deciliter, which is a little less than 7 millimoles. And this was also corresponding to the same cut point that we use for the 2-hour glucose. So because of that, the decision was made that we could use fasting glucose just as easily as we could use the 2-hour glucose to diagnose diabetes. But over time, we realized that the glucose isn't as good as we think it is, even though we've been measuring it for a long time. When they actually started doing studies to see how labs were measuring glucose and some of the errors that were taking place in the measurement, they realized that the glucose assays that are done in different labs are really not that standardized. And if you are not handling the specimen correctly, because glucose, when it's collected with the blood, and sometimes you use the fluoridated tube, which is supposed to prevent the breakdown of glucose from the cells that are in that tube. But unless the tube is put on ice, the metabolism will continue. And so if you were to use the glucose alone, you may find that the glucose will be lower the longer the specimen has been left to stand before it is processed. So you could miss people with diabetes if the specimens are not handled properly. And if labs are not doing them in a standard way, you could also make errors in your diagnosis of diabetes. And so the A1C was proposed as one of the tests that we could use to identify people who have diabetes. And this was because they had data, just like what I showed you for the relationship between the complications of diabetes and glucose. They had similar data like that for A1C. And they had been working from 1997 to make sure that the A1C test could be utilized for diagnosis, because they were standardizing the methods that were used by different labs and certifying labs as being qualified to do the A1C measurement. The A1C doesn't require any fasting. It can be done any time of day or night. There's less variability because you know if you eat something the night before, the sugar could be high. If you exercise the day before, it could be lower. There's less variability with the A1C measurement. And it's not as sensitive to temperature as the glucose is if it's not properly handled. And so eventually, the American Diabetes Association endorsed the use of the A1C, if it is done by a standardized assay, as another way of diagnosing diabetes. So you have 3 ways of diagnosing diabetes now. You have the fasting, the 2-hour glucose from the glucose load, or the A1C. All 3 methods can be used. But one of the big problems that we have nowadays is that all 3 methods don't correspond. And this is one of the first studies that they did looking at this in the US in their national survey. And what you can see here is the estimates on the amount of diabetes based on the different tests that were done. So here in the red, you'll see one circle, which shows that the prevalence of diabetes by A1C is that. The other one in the green shows the prevalence of diabetes based on the fasting glucose. So when you use the A1C alone, it's a 1.6% of the population had diabetes. When you use the fasting glucose, 2.5, and when you use the 2-hour glucose, 4.9%. So you get 3 different estimates, and it's not the same people you're picking up each time. Sometimes you're picking up, there's some overlap in some cases, but a lot of times there's still no overlap. So what does this mean? Well, I think it means we need to continue to study what happens. Most of our evidence about diabetes and what happens to it is based on the 2-hour glucose. The older studies have traditionally used that, and over time a lot more information is going to emerge about the meaning of the different approaches that we're taking to diagnose diabetes. But even though they don't all correspond, we can use any of them to make our diagnosis. So one of the things that we recognize is that you progress through the phases. In other words, you don't wake up one morning with diabetes for the most part. And so before you move to the point where you get your fasting glucose into the diabetes range or your 2-hour glucose into the diabetes range, there is an in-between range. An in-between range for your blood sugars. And this is what they have designated as prediabetes. And the prediabetes is a kind of umbrella term, because in the old days you talk about impaired glucose tolerance, and that was because you were doing the glucose tolerance test to diagnose diabetes. When they started using the fasting, they started talking about impaired fasting glucose, because you're now using the fasting glucose alone to make the diagnosis of diabetes. But if you have any abnormality in either the fasting glucose or the 2-hour glucose from the glucose tolerance test, then we classify everybody with abnormalities on either test as having prediabetes. So prediabetes is an umbrella term that can mean that your results are not in a normal range, but they may not yet be in the range at which you have diabetes. And regardless of the method that is used to make this diagnosis of diabetes, we recognize that whether you're using the glucose tolerance test, the fasting glucose, or the A1C, people whose values fall within that in-between range are at higher risk of going on to develop diabetes. So even though they may not all be recognizing the same group of people, and you may get different estimates from using different tests, once your test is coming up in that in-between range, and you're classified as having prediabetes based on the fasting glucose or the total glucose, or even an abnormal A1C now, you are at higher risk of going on to develop diabetes. And in particular, we're talking about type 2 diabetes, because type 1 diabetes progresses very quickly. And so our ability to screen for it is really not very helpful, because by the time we're to identify people who have it, they would have already developed diabetes. But type 2 diabetes, where there's a long window between the abnormality being present and disease occurring, you have a longer window within which to work. So prediabetes now would include any of the following 3. Either an abnormal fasting glucose, so a normal glucose is a value of 5.5 or less. Diabetes is a value of 7 or more. If you are 5.6 to 6.9, you are abnormal, impaired fasting glucose. You do your glucose tolerance test, a value of 11.1 or higher is diabetes. A value of less than 7.8 is normal. If you are between 7.8 and 11, based on your glucose test, you have impaired glucose tolerance and you meet the criteria for prediabetes. And now with the A1C, if your A1C is less than 5.5, you are normal. If your A1C is more than 6.5%, that's diabetes. So if you have an A1C between 5.6 and 6.4, you are classified as having prediabetes. And I'll just say one thing about A1C, which is that the A1C has to be done by a certified method. So if it is not meeting the international standards, you really should not use the A1C for diagnosis of diabetes. And we'll talk a little bit about that with some data that came out of the Caribbean recently. So prediabetes in itself is not a clinical entity, not something that we're going to diagnose, to treat. It is really something that we are recognizing or a way of identifying people who are at higher risk of going on to develop diabetes. And that is the reason why we're interested in identifying it and treating it. So the prediabetes is not a diagnosis as an end-all in itself. It's identifying somebody who is at higher risk. And we also know that people who have prediabetes are likely to have other abnormalities which put them at risk for other complications. So they're more likely to be obese, more likely to have hypertension, and more likely to have abnormal cholesterol. Specifically, we're talking about your HDL cholesterol being low. That's the one that reduces your risk of heart attack, stroke, and cardiovascular disease, or your triglycerides being high, which may also increase your risk of problems. So why the issues about A1C, I kind of want to talk about with the next slide, which is data from Barbados, which was recently published from their Health of the Nation study. And what they were looking at were a couple of things. They were looking at how common diabetes was in their population and also how common prediabetes was. And they actually did the A1C assay using standard method, and they were looking to see how the choice of their screening test would affect the estimates that they were getting about diabetes burden. When they used the fasting glucose, the number of people who had diabetes based on that, or the A1C, was similar. So about 3.5% of the fasting glucose or 5% with the A1C overlap in terms of the estimates, because it could be 3.5 or it could be lower or higher. You see a lot of overlap between those two values. But when they did look at prediabetes based on fasting glucose and A1C, there was a big difference. Because if they use the A1C, what they're getting was that nearly a third of the population, adult population, would be having prediabetes. And whereas when they use the impaired glucose tolerance, about 15% of the population that had prediabetes. We don't have any similar data like that for Jamaica at this time. So hopefully that will come one of these days. But these are big differences, and so the choice of the test can influence how you're going to approach things. And we'll talk a little bit about the evidence that we have to act on prediabetes based on different criteria. One thing about A1C that you have to remember, which is very important, is that A1C has some ethnic differences. So they have noticed that A1C does tend to run higher in black populations than other populations. So you have to be careful, especially as people get older. A1C can be affected by hemoglobinopathies. So like in Jamaica, we know we have a lot of sickle cell trait. And one of the things that we have noticed, and that came out very recently in a big paper in the US, was the fact that if we're using A1C in patients who have sickle cell trait, we are more likely to underestimate the amount of diabetes that is present. So that could be a problem. The other thing that we are finding about A1C is that it's also affected by iron deficiency. So people who have iron deficiency will have higher A1C. So there's a lot of things we have to kind of figure out about what is the best test to use. So in our population, maybe not everything that we're seeing from North America applies, because we have a higher prevalence of sickle cell trait, you have a lot more anemia, particularly in our women who are at highest risk. And so we have to kind of think around some of these things when we make decisions about how we're going to screen and identify those at increased risk. So I'm just going to speak about type 1 briefly, which is that we don't quite understand what causes it. We don't quite understand type 2 diabetes either. For type 1, we know it's a combination of autoimmune conditions and genetic factors. So if we are able to measure antibodies to different aspects of the pancreas, we can sometimes identify persons who are at increased risk for going on to develop type 1 diabetes. We don't understand what the environmental triggers are that may start this autoimmune process, and we don't quite understand everything about how the genetic and autoimmune factors interact to produce the disease. We do know, however, that in clinical trials that have been done to prevent diabetes in persons who have antibodies, none of these clinical trials have shown any benefit. So for type 1 diabetes, there's really no evidence that we can prevent it. So identifying those who are at increased risk, right now the only thing that can be done is to advise them about symptoms of diabetes, that if they should occur, they recognize that this could be happening and that they can go ahead and have themselves evaluated early. With type 2 diabetes, we have a little bit more understanding. We don't quite understand everything about it, but there are some things that we know will definitely increase risk. And so these would include age, genetic factors, and this will be covered by whether you have a first-degree relative with diabetes. Ethnicity is something that you'll see coming up in the foreign literature, in the American Diabetes Association, and they're saying ethnicity meaning black and Hispanic and Native American, but we know we have predominantly one thing out here, so that may not be so important. And then people have problems with the ethnicity issue because sometimes it labels some races as having some kind of specific problem, and so that leads to some cause of reinforcement of racist philosophies about who is more predisposed to what, etc. And we know that what we see on the outside doesn't really reflect our genetic makeup. So we say ethnicity, meaning talking about the culture, so the Jamaican people, because of not just how they look, but how they behave, is what puts them at increased risk. And we know some other things may put you at increased risk early. So a child that is born overweight or even underweight, because they've shown where mothers have been starved in pregnancy, those children who are born small have a higher risk of developing diabetes later on. But also we know that the children that are born big also have a higher risk of developing diabetes later on. And of course, we understand now better what is happening even before we are born, around the time of conception, where a mother's environment, particularly if she has diabetes in pregnancy, does increase the likelihood of that child developing diabetes at a younger age than even the mother had it. So those are things that are not modifiable. The other risk factor, which I haven't put here, but is very important for our setting, is gender. So whether gender, meaning, when I say gender, I guess male versus female, because what we see in the Caribbean is very different from what you see in the US and Europe. In other settings, diabetes, for the most part, for the predominantly Caucasian population, is primarily a disease of older men. And that is because there's a very big difference in the distribution of obesity. In the Caribbean, when they've looked at all the studies that have been done in the region, being a woman puts you at higher risk of developing diabetes. And that's very different from your risk calculator. So I'll talk about that when you do it. You should double up if you're a woman, turn it the other way around. If you're in the Caribbean, give yourself 2 instead of 1. You also know that there are some other things that are modifiable. And these would things like obesity, being sedentary, having high cholesterol or hypertension, smoking, and diet. I put the diet in specifically because right now, one of the things I was watching recently when they've had a campaign now about the sugar-sweetened beverages. And one of the things that they say is that drinking sugar-sweetened beverages increases your risk of type 2 diabetes. Yes, it does. But what we have always been trying to get people around is that it's not so much sugar, because very often people believe that eating sugar is what gives you diabetes. And I don't know if this message may sometimes reinforce previous concepts that sugar-sweetened beverages give you diabetes. But we know if sugar-sweetened beverages lead to obesity, that will increase your risk of diabetes. So it's kind of a bit of a tricky situation. When you look at studies of diet and risk for diabetes, you know that certain kinds of foods, like diets that are higher in plants and unsaturated foods, are better, and those people who eat that way have a lower risk of diabetes. But the directness of the association is not as strong as it is for other things like obesity or being sedentary. So it may be kind of working through one of the other mechanisms. So something to think about. So one of the big studies that they had been looking at for diabetes prevention was a diabetes prevention study. And a lot of it was because they had felt at that time when they were planning the study was that there was enough information that they had about risk factors for diabetes, particularly those which were non-modifiable, but also they had recognized that there were a lot of risk factors which were modifiable and which could be addressed to control or prevent diabetes. And one of the risk factors, if I can get this slide, is obesity. That was a big one. And this is one of the studies which was done in the same group of Native Americans, a team of Indians, where they looked at the effect of body mass index on the risk of going on to develop diabetes. And what you can see here is that as your body mass index increases, your risk of going on to develop diabetes increases exponentially. So that is a very strong risk factor. So they knew that obesity was one of the big risk factors, and if something could be done to address the obesity issue, you could also help to reduce your risk of diabetes. So this is what we know happens with diabetes, that at least for type 2, we believe what happens is that people who are overweight or obese are insulin resistant. And so that's what you see in the second row of that slide, where you're seeing what is happening. So being sedentary, being overweight makes you insulin resistant. Insulin resistant state means that for you to keep your blood sugars within a particular range, the pancreas has to be able to make more insulin to control the blood sugars. As long as your pancreas is able to make more insulin to meet this demand, your blood sugars are going to be normal. The pancreas is working overtime, but your blood sugars, as far as you can see, are fine. And so that's what you see reflected there, that the blood sugars have remained normal. But the longer this insulin-resistant state persists, so in other words, if you're overweight, if you're inactive, you have this level of insulin resistance, the pancreas is able to counter some of it by making more insulin to keep your sugars normal, but over time, the pancreas is going to burn out. And the burnout of the pancreas will manifest itself a couple of ways. The first place that we'll begin to recognize that the pancreas is beginning to burn out is when we challenge you, which is why sometimes people will prefer the glucose tolerance test. So the fasting levels will be okay, but if you are to be given a glucose load and you check your blood sugar 2 hours later, you'll actually begin to see that your sugars are not that okay, that maybe you are in a pre-diabetic state. And so if you see on the top slide there, the yellow line represents the fasting glucose and the orange line represents the 2-hour glucose. And the first abnormality that you usually will see is the 2-hour glucose going up, and then the fasting glucose will go up. And of course, it's really, there's a threshold that we have created, because you don't go from 5 to 7 overnight. You go from 5.5 to 5.7, then 5.8, 6.1, until you get to 7. You don't go from your 2-hour from 7.7 to diabetes. You go 7.8, 7.9, 9, 10, 11, and then next day, one day you do it and you're at 11. So this is a transition process that takes place. And so we want to identify people who have prediabetes for a couple of reasons. One is that we know that prediabetes doesn't always progress to diabetes. People who have prediabetes are more likely to go on to diabetes. Some may go back to normal, but the majority will continue to progress. And we know that this is a useful point for intervention, because sometimes when we're saying things to people, if they don't perceive that their risk is high, they're not going to do anything. But the motivation is actually higher when people recognize that their risk is higher, is increased. And so sometimes, even though we could intervene at a much earlier stage, intervening when people recognize that their near-term risk is high is sometimes more effective. Not the best way, but sometimes more effective. So this is what we have here in Jamaica. This is obesity. This is men and women. And one of the reasons why I say the risk calculator could be very different in our setting as opposed to in the US. There's a female predominance of obesity. And I remember when I presented one of this, I had one with overweight obesity and one with obesity alone. And then when I was presenting obesity alone, somebody was saying, no, yeah, that's overweight obesity. I said, no, that is just plain obesity. And what you're seeing here is that for women, by the time they're in their mid-30s, about 60% of them are overweight or obese. And then when you're in your mid-30s to 40s, 70 to 80% of women are overweight or obese. In men, it's about half of that. So you can see here, if obesity is a big risk factor for diabetes, then you have a very high prevalence of obesity. And then this is kind of also reflected in the data. This is glucose based on fasting, diabetes based on fasting glucose. And you can see here the female predominance of diabetes, where you have 9.3% prevalence in women, 6.4% prevalence in men. So it is a predominantly female condition. And this has a number of implications, because we spoke about a couple of the non-modifiable risk factors like gestational diabetes or large babies. We know that women who are overweight will have bigger babies, and women who are overweight are more likely to have diabetes in pregnancy, even though they don't recognize it. And if obesity is starting in the reproductive age group, so it's not starting when you're 50 and you're not having children, it's starting when they're in their 20s and 30s, a lot of those babies are being exposed to an environment, intrauterine environment, that predisposes them to type 2 diabetes. The diabetes prevention study is probably one of the biggest studies that has been done to look at the prevention of diabetes using, it was actually the first study which actually used medication, but it wasn't the first diabetes prevention study. Actually, the very first diabetes prevention study was done in China. It wasn't the best clinical trial, but it was a simple study where they were looking at diet, exercise, or both diet and exercise. And from that study, they were able to show that people who had modified their diet or were more active were able to reduce their risk of diabetes, and that this reduction in diabetes risk was important. One of the things that we often talk about is not so much preventing diabetes, because over time the effects of any intervention will not be as strong. But one of the things that we believe is very important is that even if you're not able to prevent diabetes altogether, the delay in the onset of diabetes is just as important as prevention. So if you can prevent somebody from getting diabetes in their mid-30s into their 50s, that is actually a lot. That is as important as preventing them from developing diabetes at all. Because if we think about diabetes and the complications, most of the complications are related to duration of diabetes. So if somebody doesn't get diabetes when they are 35 or 45, and they get it when they are 55 or 65, the impact that diabetes will have on their life and life expectancy will be much less. So the importance of delaying, and not just preventing, but even delaying diabetes is important. The first sort of more aggressive clinical study was the Finnish diabetes prevention study that was done in Finland, and that was a lifestyle program. And then I'm going to talk in some more detail about the diabetes prevention program. So the diabetes prevention program was based on a lot of the data that a number of investigators at that time had collected. And they were able to show that from their information, the prevalence of diabetes was higher as your weight increased and also with sedentary lifestyles. And so what they decided to do was to set up this multi-site study within the US, where they're looking at a number of settings to see whether or not they could develop an intervention or a program that could reduce the risk of diabetes. They set up the clinics around the country to make it accessible. They wanted people with various ethnicities, so they wanted to make sure they had intervention which could be applied to more than one population: Asian, Native American, Black, Hispanic, Caucasian. And their criteria was that they had to be people who are likely to develop type 2 diabetes. So because of that, they used an age cutoff of 25 for the intervention. And for their inclusion criteria, they used a 2-hour glucose from a 75 glucose tolerance test, 75 gram glucose tolerance test. This is important because most of the prevention studies have been done on persons who have been doing the 2-hour glucose. So that is an important thing. They have a couple of them. They may have abnormal fasting glucose, but the 2-hour glucose is what the basis for most of these prevention efforts have been. They all had to be overweight. And so these were specifically because, remember, you can have pre-diabetes in somebody who has type 1 diabetes. It's possible you could find somebody, but then if you are over 25 and you're overweight, the diabetes that you develop is more likely to be type 2 than type 1. And so what did they do? They took the people who met these criteria and they randomized them to 3 groups. I hope I have three groups. One was a placebo group, so everybody got general lifestyle intervention, and then one group went into an intensive lifestyle program, and for the intensive lifestyle program, their goal was to reduce their weight by 7%, and we'll talk a little bit about that. And this was done through a change in diet and focused primarily on reducing fat intake in the diet and increasing their level of activity to 150 minutes per week. So they use a week as a goal rather than a daily thing. So you could work it out according to your schedule. This was the first study that looked at a drug, and the drug that it chose was metformin in terms of the treatment. And so you titrated the dose, and the dose for prevention was 850 milligrams twice a day. So you titrated them up until they reached that dose. If they weren't able to tolerate, then you would stop at a particular dose that you had left them at. The study actually had a 4th arm, which was a drug which is a TZD, which is no longer on the market. So by the time they reported these findings in 2001, they had 3 arms to the study: the intensive lifestyle arm, the metformin arm, and the placebo arm. And so they checked them every year for their blood sugars to see whether or not they had reached the diabetic level. Every 6 months they did a fasting glucose, and every year they did a full glucose tolerance test. The lifestyle intervention was very intensive, 16 lessons. So in other words, it's not just giving advice, because everybody got advice, which is what we typically do. And we say, oh, you must exercise, or this is a detailed program where you go step by step, trying to induce behavior change. So it must be administered over a period of at least 12 weeks if you really want to have sustainable changes. We had a case manager and somebody who would also pull out things that they call their toolbox. So from the toolbox, if the person needed more help with their eating, you could send them in to see the dietitian. If they need more help with the exercise, they could get an exercise specialist. If they're having problems making choices, you could have a psychologist, behavior specialist. So these were all tools that were available to participants in the study. The population was eventually predominantly Caucasian, but you had a mix of different ethnicities. And it was predominantly female, and they were deliberate about making sure that they included an older population as well, over 60, not just the young ones. And this is really what happened when they started the study in terms of their weight and physical activity. So what you can see here is that those who were on the metformin, there was really very little change in their activity, not much different from those who just got our routine lifestyle advice, no changes there. The ones who went into the lifestyle program actually had a big increase in the levels of physical activity, and this was sustained over the whole, most of the thing on average over the 4 years that the study was being conducted. The study was actually ended prematurely because they saw the big differences that were emerging from the treatments that were given. When you looked at weight, for those who receive just routine advice and placebo, very little change in weight. When you looked at the metformin, people lost about 5 pounds on average, and then over time the weight began to creep back up to where they started. Those who are in the lifestyle group, they lost an average of about 15 pounds. And even though over time the weight started to go back up or creep back up, it never reached back to where they were initially. These are the results overall for the population. So when you looked at the persons who, so the people at the top are those who receive the placebo, the green at the top, and what you can see is how quickly they progressed from their pre-diabetes to diabetes over the time. The people in between is the metformin group, that's in the black. And compared to those who just received routine advice, they were 31% less likely to develop diabetes than those who did not, than those who just got routine advice. And then when they looked at lifestyle produced a reduction of 58% in risk compared to just routine standard advice. When they looked at it according to men and women, there really was not any difference. In other words, that lifestyle, the effect of lifestyle and metformin compared to the placebo was similar for men and women. But one of the areas where it's very critical to look at is this difference in the effectiveness of different interventions by age. So this was one of the, there are two groups where they recognized that there was a difference in the effectiveness of lifestyle versus drug. So when you look at the elderly, the people over 60, and you compare against placebo the effect of metformin, you will see that there's not much difference between the rate at which people develop diabetes when they got placebo versus metformin. Lifestyle actually was much more effective. So if you look at people over 60, there's like nearly a 70% reduction in risk of diabetes. When you look at people who are in the younger age group, and you're comparing lifestyle with metformin, what you notice about the risk in the 25 to 44, when you compare lifestyle to metformin, they are looking like they're working the same. And so one of the things that it pointed out is that maybe there are specific groups that benefit from certain therapies. And one of the things that came out of this study was that the elderly didn't get as much benefit from metformin. In fact, metformin wasn't much better than doing nothing. But younger persons or persons with elevated fasting glucose actually benefited more from metformin than even lifestyle therapy. So you have to target sometimes which person will get what intervention. So metformin, if you're looking at metformin efficacy, people who are in the highest weight category and in the youngest age group, those are the ones who benefited most from metformin. Older persons and people who are in the in-between age weight, overweight, didn't get as much benefit from metformin. Okay, my slide. And then, of course, they've done follow-up of these persons over time, 10, 15 years post-intervention. And then one of the things that they begin to recognize that the longer you continue to follow the persons, the smaller the differences in the benefits appear to be. So in other words, that over time, the reduction in risk of diabetes is getting closer to what you got for the lifestyle as what you got in the metformin group. So even though there is a sort of collection, they never do come back to exactly the same thing, but they do get closer. And then when they look at certain things, they're not really beginning to see by the treatment differences in some of the complications from diabetes that you would expect. So at 15 years, 27% of those who were in the lifestyle had developed diabetes. 18% of those who were given metformin had developed diabetes. Cost effectiveness is a big issue because you saw with the lifestyle intervention, it's very intensive. It's not just about giving advice and they're going. It is a structured program that has to be followed and people work through their goals until they make the changes. And so lifestyle is one of the things that is very expensive upfront because the costs are there. Over time, you begin to maybe get some of the benefits of the cost. Metformin is the cheapest option. And so some people looking at it from a macro level might say it's easier for us to pay for metformin and let the pharmacist dispense it rather than have this pharmacist spending 16 hours giving advice to one patient. So you will decide in your pharmacy whether you're going to give metformin or advice. And who is going to pay for it. So that's one of the big issues that we have. I'm going to skip over this slide. So some of the things that they're interested in is trying to make the lifestyle intervention cheaper, because compared to metformin, it's not going to be cheaper. And so they have shifted from the individual to the group sessions. And so there are a number of studies which have shown that group treatment, so having 10, 15 people at a time versus working on a one-to-one basis can still be effective. They have looked at doing it online with videos and other things rather than face-to-face to see if that can work using social media and different apps, and that has been beneficial. And so they're trying to find ways of making lifestyle more cost-effective. And for those of you who were around many years ago, well, not so many, you remember this workshop that we had where the people from University of Pittsburgh had come down and they had done the curriculum for the diabetes prevention. and you remember those, it was 2 days of training for those who were there, 2 full days going through each of those chapters and working all the material that patients would get to help them to make the changes. So in addition to the diabetes prevention study, there are a number of studies which have looked at other medications that can reduce the risk of diabetes. The DREAM trial is a very old one. They're looking at ramipril and also rosiglitazone, which was available at that time, to prevent diabetes. And so they're comparing both groups, again, selecting people with impaired fasting glucose and looking at what happened to them over time. And one of the differences, of course, is that in terms of weight, when people are put on rosiglitazone, because remember the TZDs tend to increase your weight, there was an increase in weight in those persons who received it compared to those who received placebo. And the body mass index went up. But when they looked at the risk of diabetes, what they found from the rosiglitazone was that the rosiglitazone reduced the risk of diabetes by 58%, which is the same that we saw with the lifestyle intervention from the diabetes prevention study. The rosiglitazone is no longer on the market, so that's a sort of historic thing. So here's your graph showing what happens in terms of the incidence of diabetes with the placebo and a much lower incidence of diabetes over time using the rosiglitazone. And so they were looking at whether it would be a good drug to use. At that time it was very exciting. We know a lot more about some of the TZDs now in terms of risk, and so we come I'm giving you a full overview and then I'll tell you why certain recommendations have been made at this time. The other study that we had was ACT-NOW. ACT-NOW was with pioglitazone, and pioglitazone was a much smaller study, 600 persons. Again, the same criteria, impaired glucose tolerance, and then they randomized them either to placebo or pioglitazone starting at 30 and going up to 45 milligrams a day. And again, what you can see here is the difference in the incidence of diabetes over time, where those who were on the pioglitazone had a much lower risk of developing diabetes. The risk was cut by nearly 80% from this estimate from this study. The other one, which was very popular, is the STOP NIDDM trial. And this was one that was looking at multiple countries, and they randomized persons to either acarbose or to a placebo and looked to see whether or not there was any difference in diabetes risk over time. Well, one of the big problems with this study is that because of the side effects from the acarbose, a lot of people dropped out of the study. So those who know acarbose know that when you're trying to get to that dose of 100 milligrams 3 times a day, there are a lot of people who will leave you alone. And so they had a lot of dropout. And so that's one of the issues that had affected even the analysis of some of the data to interpret it. Because, you know, in clinical trials, when you have a lot of people dropping out for different reasons, you can't be sure of some of the effects, whether it is an effect from a subgroup or not. But they were able to show that with the use of acarbose, they were able to reduce the risk of type 2 diabetes, even though a lot of people didn't reach the target goal and so on. But more importantly for the acarbose was that they were looking not just at diabetes, but they were looking at cardiovascular outcomes. So for acarbose, they had a 25% reduction in diabetes risk. But when they looked at cardiovascular disease and new onset hypertension, and that's an effect which isn't quite clearly explained, the acarbose also reduced significantly the risk of cardiovascular events in those who received it. So 49% reduction in cardiovascular events, 34% reduction in hypertension incidence. The XENical study is another one, XENDOS. This one wasn't specifically for impaired glucose tolerance. This was really a study looking at the use of orlistat in people who have obesity. But when they did a subgroup analysis, they looked at a group of people who had impaired glucose tolerance and a group of people who had normal glucose to see what the effect of the treatment was on their diabetes risk. So here is the slide. It was a big study, over 3,000 persons. The orlistat dose, 120 milligrams versus placebo. And everybody got lifestyle, but what they were looking at was whether or not when they gave orlistat in addition to lifestyle, if it was more effective in reducing the likelihood of diabetes or effective in reducing weight. And you can see here that when you add orlistat to lifestyle, you have more weight reduction. And then this is the data for diabetes. So the bottom two slides are showing everybody. The bottom two graphs are showing when you look at the entire population of persons who are overweight and got orlistat versus no orlistat and lifestyle, 37% reduction in diabetes risk. But when you look at just those persons who have pre-diabetes, impaired glucose tolerance, there's a 45% reduction in the risk of going on to develop diabetes when both are combined. This is a sort of new kid on the block, and this is an injectable GLP-1 agonist, liraglutide. So you know that one of the things we understand about diabetes is the incretins. That incretins are hormones that are produced when we eat, and these incretins help to stimulate insulin production and reduce the production of hormones like glucagon. And liraglutide is one of those incretins. It's a synthetic GLP-1 agonist, so it's given by injection. And they actually looked at it in a few persons who had pre-diabetes. They had to be overweight with some sort of comorbidity. And at the end of 12 months or 2 years, they were able to show that there was a difference in the incidence of diabetes. So in other words, for those who got placebo, 6% of them went on to develop diabetes. For those who got liraglutide injections, 2% of them went on to get diabetes. So if we look at, and I hope I'm still speaking at the right thing, no medication has officially been endorsed, well, I'm reading right, by the Food and Drug Administration. I hope I'll be corrected if I'm wrong. But if you're looking at the number of medications that are available and comparing the risks and benefits of treatment, the American Diabetes Association recommends metformin therapy. So if you're going to use a drug, looking at risk, because remember, every drug, there are issues about cost, side effect, and risk. And for all of them, the one that the ADA recommends for use at this time is metformin. And that is because of the cost of the medication, its side effect profile, which even though it produces some bloating and other things, doesn't produce some of the other side effects that we might see from other medications, and tolerability. The durability of the effect, meaning that this is one of the drugs that you have the longest, the most data on long-term effectiveness, and its effective and its efficacy. So this is the one treatment that has been recommended for diabetes prevention if we're going to use a drug. We know that there are some differences, because when we compared metformin with lifestyle, and only the diabetes prevention study has done a head-to-head of lifestyle versus drug. Most of the other studies have not compared lifestyle against drug. Most have just compared drug against placebo. So metformin is less effective overall than lifestyle in reducing the risk, but for specific groups of persons, metformin therapy may be more helpful. And there are a couple populations that they think people should be targeted for metformin therapy for diabetes prevention. One was women who have had a history of gestational diabetes, that they seem to get a better benefit from metformin therapy. And again, those women would fall in the younger category, that they seem to have a reduction in their diabetes risk of 50%, which is more than the 31% we saw from metformin in the diabetes prevention study. And in terms of cost, where they've looked at the cost-benefit ratio, compared to lifestyle, metformin is coming up more cost-effective than lifestyle. So high-risk persons, those are history of gestational diabetes, those who are overweight, are good candidates for metformin therapy for prevention. But one of the things that we must monitor with metformin is vitamin B. So patients who are on long-term metformin therapy, their vitamin D levels need to be monitored. So who do we screen for prediabetes or diabetes? Because the tests that we use for diabetes and prediabetes screening are the same. These are the American Diabetes Association recommendations. Body mass index, more than 25, so once you're overweight. Other things, your first degree relative, ethnic group. If you have cardiovascular disease, you should be screened for diabetes. If you're hypertensive or have abnormal cholesterol, you're at higher risk for having diabetes. If you have polycystic ovarian syndrome, that's an insulin-resistant state. We encourage testing there. If you're physically inactive, testing should be encouraged. And if you have some conditions that can increase your risk of insulin resistance, you should be screened. Screening doesn't always involve a blood test. And so that is one of the things that you have there with your tool, your pre-diabetes risk tool. That is based on the ADA type 2 diabetes risk assessment. So these data are looking at North American populations, and they identified a number of factors that they found were things that would increase the risk of type 2 diabetes, or the likelihood of having diabetes and not recognizing that it's present. It can also be used to identify people who are at risk for pre-diabetes. So if you look at your risk calculator, you'll see that if your score is more than so and so, it talks about a threshold if you think that the person may have diabetes. If your risk is more than so and so, it talks about a threshold if you may have pre-diabetes or diabetes. So the lower threshold would identify people with both conditions. The higher threshold would identify people with diabetes. A couple differences. So they have made it easy in this case because you can put your height and weight here, and it gives you your body mass index. So these are the variables that they choose: your age, whether you're male or female, family history, and so on, to make this calculator. I think the calculator is going to be different for the Caribbean, so that's a project we're working on with one of our students, and so we're going to test it. We're going to make our own Caribbean calculator and see how well it compares with this ADA criteria. And again, we spoke about one of the things which we think would be very different in our setting as opposed to what is done typically, which is the male-female difference for the Caribbean, because we see more diabetes in women than men in our setting. So the score might change around that particular issue. Final point. Since you're saying medical management, I've done the 1 hour, so everybody is happy. You get your CME now. I can wrap up. Okay. Diabetes reversal. There are a couple of things that are coming up that are exciting, because we know that we have the pre-diabetes, and we want to prevent people from progressing to diabetes. But if somebody develops type 2 diabetes, can it be reversed? And this is something that I'm sure that a lot of the pharmacists and other people have heard. Yes, it can be done, but it needs to be done early. So whatever you're going to do to reverse it, if it starts, should be done within the first 5 years of diagnosis of diabetes. The reason for that is that the pancreas undergoes structural changes, so there's damage to the pancreas, and so even if you were to do some of the things that we're going to just mention here, your glucose is unlikely to return to where it was before. So the longer you wait to do anything, the less likely it will happen. This is getting very popular. We knew a lot about it from bariatric surgery. And one of the things that bariatric surgery showed was that even patients before they left hospital, when they had the procedure, a lot of them would be coming off their medications, or their blood sugars could normalize very quickly. And this was even before they had lost weight. So it told us one of the important things that we didn't understand was how the hormones that are produced from the stomach actually influence our glucose and glucose metabolism. So it taught us a lot about the brain, about incretin hormones, and what is regulating them. And so what about taking other options to mimic what could be a bariatric surgery? Because we're talking about medical treatment. And what has come up is a very low-calorie diet. So Merck is going to be happy. Well, not Merck, but sorry, Cari-Med. Sorry. So Cari-Med will have to get this bill for this one. So Cari-Med, let them pay half. So the very low calorie diet is actually something which was started in the UK and has been done a little bit in the Caribbean. What it is it is reducing your calories for the day to less than 900 calories per day. So it's a very low calorie diet intended to mimic what happens with bariatric surgery. Persons are put on this diet, and what we believe happens is that through the starvation process, you remove a lot of the fatty acids. So one of the things that we think give you insulin resistance is that fat is building up and blocking those insulin receptors. And so when you put them on the starvation diet, where they are forced to use this fat that has been stored up for metabolism, it actually unclogs the insulin receptors and resets them that they can now respond as they should have normally to the levels of insulin that were produced. And the first clinical trial of this was completed and reported on last year, called Project Direct. It was an open label study, so in other words, no blinding. It was done through general practitioners' offices in the UK. What they did was that they trained one of the nurses in each of the practices to administer the program, which is really a less than, well, let's see it here, less than 900 calorie diet. And so people are put on this 900 calorie diet for at least 2 weeks with gradual reintroduction of food. And the idea was that they were to lose at least 15 pounds. That was the goal. Within the first 15 kilograms, sorry, 15 kilograms, not 15 pounds, 30 pounds, 15 kilograms within the first few weeks of the program. They were not to change their levels of physical activity, so they wouldn't start anything new, but they were not to reduce their levels of physical activity. So for this now, what they would do is that they would get, they don't have Optifast here, but where they've done it in Barbados, they have used Glucerna, and it will be 3 Glucerna a day to make sure you get all your micronutrients, and unlimited water and salad. No milk, no alcohol, no dairy, just salad, water, so you can make different salad, different soup with salad and water and your Glucerna. And so the Glucerna ensures that they meet their micronutrient requirements for the day, and that's really the purpose. And the Glucerna means that they'll get their 900 calories for the day. So everything, unlimited water and so on. And for those who are able to do it, they saw a reduction in their risk of the reversal of their diabetes. So the people who actually were in the starvation diet, their likelihood of going back to a normal glucose level was 19 times that of those who did not go on this radical diet. And of course, the level of success was related to their weight. So those who lost the most weight were most likely to reverse their diabetes. Those who did not lose any weight did not reverse their diabetes. And of course, as I said, it has to be done within the first 5 years. It's usually done supervised. Usually the advice that the patients are taking off their medications, both for blood pressure and for glucose, and monitored during this period of time. All right, so we've gone through a lot of things. I'm trying to go back to my summary slide. A number of things that we know lifestyle can help to delay or prevent progression of type 2 diabetes. We know that there are several medications that have been shown to benefit or reduce the risk of diabetes, but we spoke about the metformin as the one that is probably the one that is most is considered the safest one for use at this time, and is the one that is recommended by the American Diabetes Association for cost and efficacy. That there are new things that we can do, that we can think about in persons fall through this net. In other words, if they don't reverse, don't take on the lifestyle, don't manage the medication and get diabetes, it's still not the end. If they're prepared to starve themselves and go on an advertisement for Glucerna, then maybe they can make a little money on the side. Like the last patient asked if I can put her on an advertisement so she can buy it. And that is for Cari-Med. She'll get a discount if she goes on an advertisement for them. So I believe that I told her I'd ask. So I'm asking now. So that is a number of things that you can think around. All right, so let's go back to our questions now. Hopefully now everybody has the answers. I don't know, sometimes I think I'm wrong, but anyway, you'll help me if I am. So let's see if you got the main things. From clinical trial evidence, which types of diabetes can be prevented? type 2. So we have trials of type 1 which have not shown any benefit. We haven't done any trials of preventing gestational diabetes. Actually, the only trial that has been done is one that they were looking at preventing women who had gestational diabetes from going on to develop diabetes, and that was a very short study with a TZD done many years ago. We don't have trials of any other. Which of the populations of these populations have had trials done to prevent diabetes? Chinese men and women, elderly Americans, women with gestational diabetes, obese children, or persons at risk of type 1. Who have we done clinical trials on? Except. Only one is here. You study of this first diabetes prevention study was done in Chinese men and women. We saw that the diabetes prevention program looked at elderly Americans, and that was a group that had the lowest benefit from metformin and the highest benefit from lifestyle. I didn't talk about the study of women with gestational diabetes, but I spoke about it a while ago. That was just kind of preventing them, because women with gestational diabetes have a very high risk of going on to develop diabetes. We haven't done any study of metformin, but the study that they did at the time of a TZDs was suggestive of benefit. Although that study didn't look at diabetes, it looked at an intermediate response to the drug. So that has really not been done. So I guess maybe C isn't so wrong. D, we haven't done any trials of diabetes prevention in obese children. Even though we are concerned about it, we still can't really target the children very well. And diabetes in children is a different story. Even type 2 in children is very different. We have done in type 1 diabetes, and those have not shown that any of the interventions are helpful. So we can't prevent type 1. Which of the following are proven risk factors for type 2 diabetes? And there's more than one answer here. So A, obesity, yes, we know it's a big risk factor we have here. Family history of diabetes, gestational diabetes, being sedentary, and then B is a controversial one. So indirectly, I would have to say it works probably primarily through obesity, but indirectly. And I mean, if you look at diets that increase the risk of, you might see this coming up. Prediabetes refers to which of the following conditions? Fasting glucose 5.6 to 6.9, total glucose 7.9 to 11, A1C of 5.7 to 6 point, all of the above. These are the three ways in which you can make a diagnosis of prediabetes: the fasting glucose, the 2-hour glucose, or the A1C. Those are three acceptable methods. And remember that you don't go from normal to abnormal overnight. So that's the reason why you want to identify this in-between stage. Most diabetes prevention studies have used which of the following criteria for prediabetes? B, everybody's saying B, yes. So most of the studies that we have looked at, where they're looking at prevention of type 2 diabetes, have used the 75-gram oral glucose tolerance test to put people into that study. So we haven't had many studies where it is based on fasting glucose, and we haven't had any studies, as far as I'm aware, that have looked at people with abnormal A1C. So when we look at the evidence, the strongest evidence is going to come from people primarily with the 2-hour glucose 75-gram abnormal result. Which of the following medications have been demonstrated to reduce the risk of diabetes? A, metformin, yes, pioglitazone, acarbose, liraglutide, orlistat, all of them. Yes, all of them. I'm just opening your mind to the different options that you have. All right, oops, okay, time is up. Which of the following have been approved by the FDA for diabetes prevention? Okay, well, officially none have been endorsed, but we spoke about recommendations. The diabetes prevention program found lifestyle is most effective in which group of persons? The participants over 60. That's important. So lifestyle was more helpful in the older persons. Which of the following medications have reduced the risk of both cardiovascular events and diabetes? Okay, acarbose, the metformin, I'm kind of thinking, the pioglitazone, I'm not sure, no. I remember the pioglitazone study, but I don't think, it wasn't, the pioglitazone kind of was borderline in terms of maybe some cardiovascular endpoint, but not very strong. The metformin, I'm trying to think about the CVD. I don't think there was a big change in macrovascular. It's primarily in diabetes for metformin. So I'm going to reverse that one. Not reverse it, recheck that one. So just in case I'm wrong, I'll send the correct answer back. I hate when I have to think about these things too much. Which of the following have the potential to reverse diabetes? A and C. So the very low calorie diet. That's the new fad now. Okay, so everybody got their CME. This is my last plug for those who are part of the diabetes educator group that we're having the one-day symposium in July. So we're going to go over a couple of updates for those who are interested. So I think everybody got their CME. All right, good. I've done my job.
Okay, so for the persons that are diagnosed under 5 years and they'll be interested to find out about the reversal of diabetes, how many of your colleagues are on par with trying to do that? Because many persons would love to do that, but then, you know, many doctors might not be in the loop about trying to do that. They might just want to treat you and you continue your lifestyle happily.
Right. So
what's the advice for those persons?
Yeah, so this time it's not traditional, it's not sort of rolled out. This is, it has been done under special circumstances. So the question was how many people are actually doing the diabetes reversal program. And I was just saying that it is not officially rolled out. The clinical trial was done in GP offices in the UK. They felt that they wanted to do it in a real world setting, and so they found that the nurses who worked in the clinic were able to administer the intervention with 1 day's training. That was the approach. For the Caribbean, there are a couple of things that have been tweaked. So far, the place that has done most of the work in sort of modifying the program for the region is Barbados. So in Barbados, they've actually tested the options that are available to us, and they have looked at how people respond to it, and they have done a few early studies of the metabolic response to the treatment. So at this point, we really would not have a lot of evidence for the region in terms of how it would work, but it's something that is probably likely to emerge over time. It does require monitoring, so I think that's important because they stop medications both for the diabetes and the blood pressure. So a protocol for monitoring the participants when they are coming through the phase is very important. And then also the reintroduction phase of eating. So they start with a very low calorie diet, at least for the first 6 to 8 weeks. But then food has to be reintroduced when they have lost the weight, and you actually want to reintroduce the food without regaining the weight. So that requires some choices in terms of when foods are started back and ensuring that the person's weights do not go back up, because most people, when they have gone on this kind of diet, will lose the weight, but they regain it very quickly once they go back to their previous habits. So that is one of the things that needs careful monitoring.